Everyone deserves to have an endocrinologist to fully understand all of the amazing metabolic processes that our bodies are performing. I'm Dr. Lindsey VanDyke, and this is the Endo Days. It's Dr. VanDyke, and this is part 3 of State of the Heart in America. I'm here with my friend and colleague, Dr. John Osborne, a Dallas cardiologist with over 2 decades' experience in managing heart disease. So far, we have reviewed what heart and vascular diseases are and how prevalent they are, not just in America, but the world over. We also reviewed the standards of screening and diagnosis and explored some adjunctive measures that can be very valuable in determining how aggressive treatment should be. Now, let's look at those treatments and some complementary treatments and discuss what works, what doesn't, and where the controversies lie.
Now let's talk about aspirin. There always is this ongoing debate about aspirin. Who should be on it? Who shouldn't? And again, there are different recommendations made by different professional societies. And the best example for me in my field is the American Diabetes Association wants aspirin only in patients who have already had their first heart attack. So what does the American College of Cardiology have to say about aspirin?
Yeah, so right now, let me focus on where there's not much debate. If you've had a heart attack, stents, balloons, bypass surgery, those things, what we call secondary prevention, you've had your event and you've survived, by the way. In those patients, there's absolutely no doubt. You should be on aspirin unless there's a very strong reason that you shouldn't be taking it, such as rarely allergies, more commonly would be a bleeding issue. So let me reassure everybody who is taking aspirin because you've had a heart attack, a stroke, balloon stents, bypass surgery, peripheral arterial disease, blockage of the legs, all of those manifestations of plaque, that yes, you should be taking aspirin. Of course, this all depends upon discussion between you and your physician. I think the bigger debate, and we've seen this pendulum swing both ways, is for what we call primary prevention. That is, people who have not yet had a heart attack, a stroke, balloon stents, bypass surgeries, etc. I think based on the most recent data, and literally this is just from several months ago, 3 large trials have come in, one done in diabetic patients, one done in higher risk patients, and then another done in the elderly, really showing not a whole lot of benefit in primary prevention of the use of aspirin, but clearly showing consistent across all these studies that there was a greater risk of bleeding. Not that that was common, but clearly higher than people who didn't take aspirin. So I think the one thing we can be very sure about, if you've had an event, you have known heart disease or stroke or plaque, that yes, you should probably be taking aspirin in discussion with your physician. If your primary prevention haven't yet had that, I think we're going to be a little more cautious about crop dusting the population with aspirin.
So what kind of thing would tip the scales in favor of aspirin for somebody in that position?
I think practically for the primary prevention population, if you got a positive calcium score. If you got a positive calcium score, we're really saying you have plaque, it hasn't caused you symptoms yet, absolutely I would recommend aspirin. In fact, we know that people with or without calcium, the risk of a heart attack is different by about 20-fold. 0 score, you've got less than a 1% risk of a heart attack in the next 10 years. If you have a positive score, your risk of a heart attack in the next 10 years is 20%. So I would say, I think where we're going to be going, a little bit of my own read into the data and literature, is you get a calcium score. If it's 0, yahoo, great. The risk of bleeding when aspirin is greater than the benefit, don't do aspirin. If we have a positive calcium score, there's early plaque starting to develop, then I think that's different, and we would say those patients probably should be on aspirin, and that the modest but measurable risk of bleeding is acceptable.
Okay, so let's pretend we have a patient here who we have diagnosed with heart disease, and she has high bad cholesterol, and she has a coronary calcium score greater than 0. Doesn't matter to me what the number is, but she has not had a heart attack yet. So looking at this particular individual, what would we do for her?
So the foundation of this preventative pyramid, as I think about it, of course, is diet, which we've alluded to before. Probably Mediterranean diet is probably the best vetted, scientifically proven diet. Regular exercise, and also, of course, absolute tobacco cessation. Just No forms of tobacco, even vaping, etc., I would argue is not worth the risk. So that would be the foundation of this. For her, if she had a positive calcium score, has a high LDL, then we got to go after that LDL cholesterol. Here's something that I want to clarify. Most of your LDL cholesterol is very much predicted by genetics. So if you have high LDL cholesterol, with some exceptions, generally that's going to be genetically determined. And because it's genetically determined, you can imagine that diet, lifestyle, is not going to affect your DNA or your genetics or your ancestry. That's where we get into discussion about the role of medications. We'll say in this case, I think that would be very appropriate. In fact, this is exactly what the guidelines say from the ACC and AHA. We would probably use what we call a higher potency statin that's more effective in lowering cholesterol. And probably the go-to statin, there's two of them, but I'll tell you my go-to, because I think it's a little bit better tolerated, a little more effective, would be what's called Rosuvastatin. That's the generic form of Crestor. This drug became generic a few years ago. It was fairly expensive. Now it's quite inexpensive. You could probably get a year's worth of this for as cheap as maybe $40 a year now. Very effective. That drug at the standard doses can lower the LDL cholesterol by about 55% and also is very well tolerated in most people. A study from about 10 years ago, nearly 20,000 people, they put people on placebo or a sugar pill or 20 milligrams a day of Rosuvastatin or Crestor. And what's interesting is, as you look at that study, that 6.2% of patients randomized to placebo, of course they didn't know they were taking placebo, but randomized to placebo, stopped placebo because of side effects. If you look at the people actually taking the active drug who dropped their LDL from 108 down to 55, 6.6% of the patients stopped the drug because of side effects. So 6.6% of the people who got the benefit stopped that drug because of side effects. The people taking placebo, of course, didn't get a benefit. 6.2% of those patients stopped the drug. So just to show you that most people, these drugs are actually quite well tolerated.
What about the other drugs? There's kind of ancillary drugs you can use with a statin to get better bang for your buck.
Sure. So the first line therapy would be statins. There are other drugs that work well with statins that further lower LDL cholesterol. One of those is a drug called Zetia, which is the brand name. It's now generic, called Ezetimibe. Adding that to a statin will give you another 20 to 25% reduction in cholesterol. This drug also became generic a few years ago, and as it turns out, it's now pretty inexpensive as well for patients where the statins don't get the numbers to where we want them to be, or if we have trouble with tolerability and we can't use higher doses of the statins, then adding on Zetia gives you another 20 to 25% reduction in LDL. In fact, in a large study of 18,000 people over 6 years where everybody got statins, half got Zetia, half got placebo, that the rate of discontinuation of placebo and Zetia was exactly the same, which says a lot about tolerability for that drug.
And what about fish oil? Everybody wants to be on fish oil.
Yeah, fish oil, very interesting. There's EPA and DHA. New data just came out that showed if you took a high-risk population, people with established heart disease or patients who had diabetes and one other risk factor, which would include things like high blood pressure, family history, etc., that if you then, and these patients also had modestly elevated triglycerides, that if you then gave them 4 grams a day of a pure EPA preparation called icosapent ethyl, brand name is Vasipa, that lowered triglycerides. But more importantly, that translated on top of excellent LDLs, all these patients were on statins, that it further lowered the risk of cardiovascular death, hospitalization for angina by another 25%, and was highly effective. So I think that very, very recent data, not even yet incorporated into our guidelines, but I think we will see that study called the REDUCE-IT study. We're going to see a big increase and much more widespread use of these drugs in high-risk individuals.
So for those of us who are taking statins, myself included, do you get any other benefits from them aside from cardiovascular?
So many times with statins, obviously they lower LDL effectively. They also have anti-inflammatory effects. They lower CRP. There's been a lot of other effects that may be associated with statins. Everything from perhaps better bone density, interestingly, perhaps cognition, although honestly I'm going to admit to you there's some debate. You'd think that lower cholesterol, because a lot of dementia is caused by vascular problems and blockages and strokes and recurrent strokes, that there might be a big benefit there. We've looked at that. I would say cognition or, memory issues, it's probably a bit of a wash. It doesn't look like they harm. It doesn't look like there's major benefits. Another condition would be things like fatty liver, which is a very, very common scenario. In North Texas, we have a lot of underheightness going on. None of my patients are overweight. Many of them are underheight. So particularly people who are underheight have insulin resistance, diabetes, prediabetes, that non-alcoholic fatty liver disease. Probably in the next few years, that'll be the most common reason for liver transplantation in the United States, overtaking viral hepatitis. And there may be a role for the use of statins as a treatment for this as well.
Statins get a bad rap, at least according to the patients that I see, because they have read stuff about how the statin causes liver failure, causes dementia, causes diabetes. And I know what the endocrine literature says about this, but what are your thoughts?
Yeah. So as far as liver failure and things like that, it's extremely rare to ever see liver failure from these drugs. I mean, it literally is a rare case report. I've never seen it. Dementia, again, continues to be debated, but if you look at probably the latest, greatest, best data, these drugs probably, we'd expect maybe some benefit on dementia, but as it turns out, I think they're probably fairly neutral. And then, of course, the most common thing with these drugs would be the muscle and joint aches. Do they cause them? Yes, they do. There's no question about that. If you look at clinical trials where people are blinded, that rate is maybe 3 to 5%. But I think the real message is, if you need a statin, have that discussion with your doctor. There's just a lot of ways now that we can lower LDL cholesterol.
Okay, let's go back to our pretend patient. So now she's back in clinic, and she reports that she's taking her medications on time every day as prescribed and is not missing any doses, and that can be really hard to do. What are her treatment goals? How do we know we are preventing her heart attack?
So certainly in this person that we call primary prevention, but primary prevention means you haven't had an event, but at the same time, we know that she has plaque with a positive calcium score. So I would call her 1.5 prevention. Secondary prevention means you've already had a heart attack. So I think this is a very high-risk person. I would certainly like, and the guidelines support this, that we use a high-potency statin, that we get the LDL certainly reduced more than 50% of where she started from. And as far as a number for LDL goal goes, I would shoot for an LDL similar to someone who already had a heart attack, of getting the LDL below 70. In fact, it's arguable for people who've already had heart disease that 55 is the new 70.
So there was a time when we used to recommend niacin to patients because it would help raise the good cholesterol, but that recommendation has been discontinued. So what happened?
Well, we did science. So we did 2 large outcomes trials. We added on 2 grams a day of niacin, which was certainly more than enough to give people flushing and itching, which is the most common side effect of that drug. Also raises blood sugar. And all we saw was more flushing and more itching, no reduction in strokes or heart attacks. Another trial was done that was even bigger with about 21,000 people. Also did not show benefit. So the FDA in 2016 said, we're going to pull any recommendations and what we call product information and labeling with respect to niacin added to a statin, because we just don't have any evidence from 2 large outcomes trials that adding niacin has benefit.
Are there other complementary supplements that are useful?
So there's a lot of supplements out there and a lot of stuff on the internet. We talked about omega-3 fatty acids, a lot of stuff about turmeric. We don't have any long-term outcome study with that. The other thing is what form of turmeric, what concentration, are we absorbing it or not? And then we also need to understand what's the harm. And sometimes the harm can only be seen when you have large numbers of people over multiple years taking the drug, and that's why we do these big outcomes trials with tens of thousands of people over years. Magnesium is another one that's touted. I think there's a little bit better data in science. There's another NIH trial studying the role of vitamin D, 2,000 units of vitamin D, randomized to placebo, followed out over 5 years. No benefit of vitamin D.
Can you comment on the herbal's red yeast rice and coenzyme Q10.
Yeah. So coenzyme Q10 mainly is seen as something that might help with the muscle aches and joint aches that are caused by statins. Haven't really shown much benefit of CoQ10. I will tell you at the same time, CoQ10 appears to be benign, doesn't appear to cause harm.
So if we can try to bring all of this information together, the take-home message is that every person has an individualized risk of heart disease that is based on a whole lot of different variables like family history, age, LDL, etc. And we have discussed that heart disease is underdiagnosed and undertreated, especially in minorities, but we have easy access to potent, effective, and usually cheap medications to fix the problem.
So where can we go next with this information? In Part 4 of State of the Heart, we will explore what patients can and should do for themselves now that they are armed with this information. In the meantime, you can go to www.stateoftheheart.com to learn more.